Hi all, Dr. Kane here. We're going to talk a little bit about Chapter 9, the personality disorders. I really like the personality disorders. I always enjoy teaching this particular piece of it. They are a section of DSM diagnoses that actually are diagnosable in individuals over the age of 18. So we don't give personality disorder diagnoses to children, individuals under the age of 13. And the reason for that is that we want to really show and observe a persistent pattern of personality features in order to qualify for this set of diagnosis. So in this chapter, we're going to give a little bit of a general definition of what the personality disorders are. And we're going to talk about the three clusters that DSM defines and categorizes a bunch of personality disorders within these three clusters of A, B, and C. First, let's talk about normal personality development. So our personality really affects our daily life constantly. We can think of it as our enduring patterns. And enduring, I mean patterns that are stable, patterns of perceiving and feeling and thinking about ourselves, patterns on how we relate to oneself and the environment. Really, our personality determines how one feels, interacts with others, and perceives events. We all have personality traits that are aspects of our personality that is stable across time and across many situations. So these are traits that we can see a clear pattern of our behavior, thoughts, or emotions. Some really good examples of some core aspects of our personality is really our sense of self or our sense of identity. Our sense of self is really quite stable. It doesn't really matter how many different types of environmental situations we are in. We always feel the same. We identify ourselves as the same. And we often exhibit some pretty core characteristic features across multiple situations. So we're always warm-hearted or have a good sense of humor or logical or optimistic, really kind of no matter what situation we are in. Another core aspect of our personality really comes from then how we relate to others as well too. One of the most predominant personality theories is the 5-factor model. And this is a perspective that everyone's personality is really organized along 5 broad personality traits or factors. So it's a dimensional perspective. And what we mean by that is these are the 5 personality factors. And dimensionally, you fall either on one side of the factor or the other. And so you'll see some of these factors, there's polar opposites on each end, where you have negative emotionality versus emotional stability, right? So someone who is pretty even keel, pretty stable across multiple situations versus those that can get quite dysregulated very quickly or change their emotions from one situation to the next. I'm just going to pause this for a second. I'll be right back with this COVID virus. My phone has been ringing off the hook. Okay, guys, I'm back. Sorry about that. So let me just make sure that we're recording here. It looks like we are. Okay, so I think we were on this slide here. And I think I was explaining a little bit, which by the way, these personality factors are also on table 1, page 248 in your book. It describes a little bit about the facets and the dimensions listed under each factor. So really the way that these factors, these 5 factors work is there's a dimension here where there's 2 extremes. The extroversion versus introversion is a really good example of that. And based upon, many personality inventories or questionnaires, you can measure individuals' functioning or personality features based on these 5 factors. So let's move to how one defines a personality disorder. So personality disorder, as defined in DSM, is where there's a pattern of thinking, feeling, and behaving that markedly interferes with an individual's ability to function adaptively in the world and relate to others. So typically for the personality disorders, these start in early adulthood. That's characterized by age 17 or so through 23 or 24. That's really most often the time frame in one's life where features of personality style, if they're going to pose a problem, start to interfere with the person's ability to adapt to the world and relate to others. We also see, in order to diagnose a personality disorder, we also have to see that the pattern is evident across multiple settings and environments. So we want to prove, we want evidence to show that the personality disorder is what we call pervasive and inflexible, right? It's present across multiple environments and multiple settings. We also want to see that the pattern or the problem, in terms of the patterns of thinking, feeling, behaving, are chronic, and that they are not occurring during a time in which someone is just depressed or during a time in which there might be another psychological disorder active. So we want to make sure that the personality features and problems also deviate from what the expectations of one's culture is. So obviously, in terms of what's normative, varies from one culture to the next. What's normal behavior, what's acceptable behavior varies. So when we're thinking and judging that someone's pattern of thinking, feeling, or behaving is significantly interfering with their ability to function or be adaptive or relate to others, we want to take cultural considerations into account. So let's go to this table 3. I'm going to show you several different tables that talk a little bit about these personality clusters. So again, in DSM, they basically categorize the personality disorders into 3 different clusters. And it depends on whatever the descriptive similarities are of the personality disorders. So the first chart we're going to spend some time on is the cluster A personality disorders. And this table 4 is on page 252. So paranoid personality disorder is a pattern of pervasive distrust and suspiciousness of others. An individual often interprets others' motives as being malevolent. They are preoccupied with the belief that others are trying to harm them or exploit them in some way. Often, they will seek information to confirm their suspicions, or they'll often misinterpret others' motives or misinterpret situations to fit with their own suspicions. They can be overly sensitive and bear grudges, and they often don't confide in other people because of their paranoia. The second personality disorder in this cluster is schizoid personality disorder. This is where one displays a pervasive pattern of detachment from social relationships or a very restricted range of emotion. The emotions that they experience are very blunted, so they are decreased. They can still experience positive or negative emotions like happiness or sadness, but the emotions have a sense of blaseness to them, a sense of stunted or being blunted. The person with schizoid personality disorder typically doesn't desire interpersonal closeness with others. They're fine just being a loner. And often they can be very successful at jobs or employment that might highlight this. So a person who works by themselves on third shift, or a person who might be drawn to the IT field and interact with computers as opposed to people. Those might be examples of jobs where there is minimal interpersonal closeness or interaction with others, where individuals with schizoid personality disorder might find themselves attracted to. And although they may occasionally experience and express negative emotions related to their interpersonal interactions, they're definitely generally indifferent to criticism or praise from others. They just don't desire it. They don't care for it. They're not affected by other people's opinions or praise. It just doesn't influence their behavior. Finally, in this category is schizotypal personality disorder. These symptoms are very similar to those of schizophrenia, but really in a milder form. So some of the characteristics here might be a really restricted range of emotion. The patient might feel extremely uncomfortable in interpersonal interactions, and they might display very odd or eccentric behavior. For example, their speech might be very disorganized. You might remember the concept of tangential, where the speech is all over the place. They might be very vague. They often show signs of suspiciousness of others, and they often believe that others can read their thoughts. They may have ideas of reference, and they often have perceptual distortions. Those might be seeing things a different way or hearing things a different way that conforms with some of their suspiciousness of others or some of their paranoia of others. So let's move to the next table we want to talk a little bit about, which is the cluster B personality disorders. We describe these as the dramatic or emotional personality disorders. These are people that tend to have very unstable emotions or engage in very dramatic or impulsive behavior. This table is actually on page 258 in your book. So antisocial personality disorder, this is a disorder where a person shows a pattern of disregard for others. It might involve the patient violating the rights of others. It might be individuals who are frequently arrested or engage in criminal behavior. They are often deceitful and may lie to others for their own benefit or gain. Their behavior can be very callous in that they really lack any remorse for others. They have a very difficult time seeing another person's perspective or having empathy for other individuals. Borderline personality disorder is probably one of the more common personality disorders in cluster B. There's tons of movies that have been made about individuals with borderline personality disorder. This is where the person displays a pervasive pattern of unstable self-image, emotions, and interpersonal relationships, along with having a great deal of impulsive behaviors. Their emotions can often be out of control. They have extreme mood swings. They are very hypersensitive to abandonment in interpersonal relationship. They often feel very criticized by others. They have a history of really clinging to others too tightly so that they become immediate friends, or there's often an element of being obsessed with others very quickly. They may have a history of hurting themselves, which might involve suicidal gestures or injuring themselves to earn the concern or attention of other individuals. They frequently can experience depression, anxiety, anger, and suicidality. Histrionic personality disorder is a pervasive pattern of attention-seeking behavior that can include inappropriate seductiveness or dramatic emotionality. Individuals with histrionic personality disorder often experience or display a lot of sexualized behaviors. They may frequently flirt with others. They often might cling to others because of a deep sense of their own self-doubt, or they feel an unstable identity, and so they seek that constant approval from others. They might quickly mimic others, take on their behavior, their sayings. They may become immediately connected to other individuals upon first meeting them. Often that involves a very intimate connection. And they often perceive relationships, again, as being really more intimate than what they really are. Narcissistic personality disorder is the last personality disorder in this cluster. This is where the patient displays a pattern of behavior characterized by an exaggerated sense of self-importance. They have a lack of empathy for others. And they often have an excessive need for admiration. So they often demand being the center of attention. Sometimes they will use or hurt others for their own gain. They may have a belief that one is special and entitled to special treatment. Individuals with narcissistic personality disorder also have a high rate of co-occurring substance abuse, mood disorders, and anxiety disorders. So what we mean by that is they often fit the criteria for not only narcissistic personality disorder, but some other disorder as well that is related to substance abuse, mood, or anxiety. So the last table that we're going to talk about includes cluster C personality disorders, and those are the anxious, fearful personality disorders. Let's start with avoidant personality disorder first. So this is where the patient displays a pervasive pattern of social inhibition, right? Being extremely socially shy, low self-esteem, and severe anxiety in social situations. It's a little bit different than what we talked about in terms of agoraphobia and the social phobias. Where in agoraphobia or the social phobia, there might be a fear of getting stuck or being unable to escape social situations, so therefore they are avoided. With avoidant personality disorder, social situations are avoided because the individual has a fear of being criticized by others. The patient may be prone to experiencing deep shame. They typically desire social relationships, where in contrast to those individuals with schizoid personality disorder who often prefer to be alone. The person with avoidant personality disorder craves those social interactions and has a desire for it, but avoids those because of their anxiety or their fear of being criticized. Dependent personality disorder involves a pervasive pattern of behavior marked by a deep-seated belief that one cannot care for oneself. They often deny their own thoughts, feelings, and needs in order to please and be compliant with someone who can take care of them. So that often they're even willing to endure abuse or exploitation in order to feel connected to somebody else or cared for by that person. They have, as one would guess, they suffer from really profound low self-esteem, and they have difficulty sometimes even making decisions about even minor day events and activities, and really depend on the other person to make their decisions for them. Obsessive compulsive personality disorder is a pattern of behavior characterized by excessive concern with perfection and having things a certain way. It's associated with a person having very rigid beliefs and control over one's environment. Their emotions are often overly controlled, and they're often workaholics, in that they have a great difficulty relaxing or having any leisure time. They rigidly follow rules and schedules, and they can often become very upset when rules are not followed, or when the rules are not followed, or when something interferes with their plans. So it's a little bit different than similar disorder as obsessive compulsive disorder, but one might remember in obsessive compulsive disorder, it's a hallmark feature to have compulsive thoughts or patterns or behaviors that one engages in, like hand washing or doing or undoing or checking behaviors. Those behaviors are absent in individuals with obsessive compulsive personality disorder. And so it differentiates the two diagnoses by either the presence or the absence of compulsions or behaviors. The last slide I want to talk about this, because we always end our chapter in thinking about disorders from an integrative standpoint. And I'd like to talk a little bit about what are integrated model is for personality disorders. And so here we're thinking about personality disorders as one who has a biological disposition of a difficult temperament that then is paired with ineffective parenting. And that's what we believe right now is an integrated model in terms of what causes personality disorders. We know that several personality disorders are associated with adversities that people experience in childhood. That can include abuse, neglect, parental instability, or parental mental health. And so if you're looking here at the screen, you can actually see how there's a combination of biology as being a biological predisposition to have a difficult temperament, which is paired with parenting that is harsh, critical, or unsupportive, or it alternates between being overly protective and indulgent. And what I mean by that is being overly protective or intrusive in the child's life, or indulgent, that they give in to the child. They try to meet their every need. They spoil them. They're indulgent to them. And so what we believe here is that it's a combination that even though if somebody is born with a biological predisposition to a difficult environment, it's that type of parenting that they receive or those experiences in their early childhood that really begins to trigger some behavior and emotional problems. And it begins to trigger some of these maladaptive beliefs about one has about themselves. And then once these behaviors are acted and once these behaviors are displayed, they elicit very negative reactions from peers and adults, which then increases and solidifies the maladaptive problem and the maladaptive interaction between themselves and others, right? So you have what starts off as a biological predisposition is then triggered by something in the environment, and then based upon the reaction that one receives from the environment, it reinforces and perpetuates that maladaptive pattern of identity. So that's our chapter on personality disorders. I hope you enjoyed it, and we'll be back again soon with the next chapter, which will be eating disorders. Thanks all. Be safe and be well.